Hi, my name is Kunal, and in this video I will be talking about modafinil. So modafinil goes by a few different names, one of them being 2-diphenyl methyl sulfonyl acetamide, and the other is its commercial name, which is Provigil. It's a wakefulness promoting drug, and it's known as a eugeroic. Eugeroics fall under a class of drugs that are known as nootropics. These are basically substances that improve cognitive function in healthy individuals. A few other examples of nootropics include amphetamines and methylphenidate. So the history of modafinil begins in the 70s, where a group of researchers at Lafon Laboratories developed a drug called adrafinil. Adrafinil is basically the R enantiomer of modafinil, and it has a longer half-life. And eventually these researchers wanted to develop something that was more fast-acting, and that led to the development of modafinil. And by the early 90s, modafinil was being marketed in France as a treatment for narcolepsy. And then by 1998, this drug was approved by the FDA in the US for the same purpose. And today, it's classified as a Schedule 4 drug. Aside from its wake-promoting properties, there have been a lot of studies that have suggested that modafinil may actually have a different mechanism of action than that of amphetamines. And as a result of this, modafinil has a lower liability of abuse, and it has a lower risk of adverse effects on organ systems. One specific example is the cardiovascular system. In one study back in 2000 by Florence et al., the researchers found that modafinil actually results in a smaller increase in heart rate than amphetamines, and it also produces no change in arterial blood pressure. And as a result of these properties, this drug could actually be used as an alternative treatment to conditions such as ADHD, depression, cocaine addiction, and schizophrenia. Modafinil is a racemate of the R and the S enantiomer. As I mentioned before, the R enantiomer is adrafinil, and it has a longer half-life. The S enantiomer has a shorter half-life, and regardless of the difference in the half-lives and some differences in the pharmacokinetics, they both produce similar effects on the CNS. Also, modafinil is highly lipophilic, and it's taken orally. So modafinil acts on the catecholamine systems. Its primary effects can be seen on dopamine and norepinephrine. Modafinil has a modest affinity for the dopamine transporter, and it leads to increases in extracellular dopamine in the prefrontal cortex, the medial hypothalamus, and the nucleus accumbens. Modafinil also weakly binds to the norepinephrine transporter, and it leads to increases in the prefrontal cortex and the medial hypothalamus. Modafinil also has secondary effects on serotonin, glutamate, GABA, orexin, and histamine. It leads to increases in serotonin in the prefrontal cortex, the medial hypothalamus, the central amygdala, and the dorsal raphe. It leads to increases in glutamate in the ventromedial thalamus, the ventrolateral thalamus, the hippocampus, the striatum, medial preoptic area, and the posterior hypothalamus. It leads to decreases in GABA in the cortex and also in areas where there is an increase in glutamate. We also see increases in activity with regards to orexin in the perifornical areas, and there is an increase in histamine in the hypothalamus. So there have been numerous studies that have shown the benefit. In conclusion, the research of the past 2 decades has given us a better understanding of the pharmacological effects, the physiological effects, and the behavioral effects of modafinil. However, more research still needs to be done. A few examples of some research that still needs to be done today includes assessing the intracellular effects of modafinil as well as the effects on psychiatric populations. Thank you for your time, and I am available to answer any questions.